Welcome to those of you who are joining us. We'll give it another minute before we get started. All right, I have 4 o'clock, so we are going to get started. My name is Margie Beaudry. On behalf of Trust for America's Health, I'm pleased to welcome you to today's Huddle call to discuss challenges and solutions for ensuring access to the COVID-19 vaccines for older adults and people with disabilities who cannot leave their homes. Please mute your line unless you are speaking. This session is being recorded so that we can capture all of the ideas and experiences shared. This call series is part of an initiative to identify and foster adoption of innovative and promising practices on this topic. This work is made possible through the generous support of the John A. Hartford Foundation and the Cambia Health Foundation, both of which are dedicated to improving health for all. When TIFA began this initiative in February, very little was known about the challenges of ensuring that older adults and people with disabilities have access to the COVID-19 vaccine. And since that time, CDC has produced guidance. Additional funding has become available through the Administration for Community Living, which we heard about recently, and there has been much media attention focused on this issue. Working together with many of you, we have developed a set of policy recommendations that will soon be published and disseminated to help inform and guide policy leaders across the country, as well as some very practical guidance that will be posted on TIFA's website today, and that will be the subject of today's presentation. Despite the increased attention to this issue, there are still a lot of complexities, including the developing situation with the J&J vaccine, which has now come back into use, but is still being watched carefully. And many states and local jurisdictions have yet to fully identify their homebound populations or have been able to implement systematic strategies for vaccination distribution to those at home. In today's Huddle call, we are introducing a brand new tool published today on TIFA's website. The Guide to Innovative Practices catalogs all of our learning from the past 3 months related to access to vaccines for those who are homebound. A companion piece to the policy brief, which will soon be released, this tool is like a field manual. It contains practical suggestions for taking action at the local level. As homebound COVID-19 vaccination efforts continue, so does the evolution of practices to support them. And this guide is designed to assist those who are organizing homebound COVID-19 vaccination programs and detail innovative practices across the country, including the essential role of non-traditional partnerships. If we have learned about the use of a practice by a particular agency or organization, it is noted in the guide, along with considerations for adapting the practice for implementation elsewhere. So we'll spend some time today talking about what you'll find in this tool, and then we'll open it up so you can see it in real life. There is a section at the start about how to get started, and then the key areas of innovative practice are organized into 8 categories. When you're in the guide, you can control-click on these categories to go directly to the sections that interest you. And all of the sources we used are provided at the end of the tool. Several questions need to be answered at the outset of a program to determine the best course of action. And that includes who's in charge, who are we vaccinating, how are we scheduling and delivering immunizations, and how are we funding these vaccine delivery efforts? And there are many sources at the end of the guide, including several guidance documents that CDC has developed, which state, tribal, local, and territorial health departments and their partners should find very helpful. And then next, I just want to show you just a little peek into how this works. So the practices included in the guide are organized into 8 categories, as I said, and this slide shows a snapshot of part of one category. It starts with a brief summary of the category, in this case, proactively registering the homebound for vaccination. And then there's a 3-column table. Column 1 has a description of each practice. Column 2 includes information on where that practice has been done already to the best of our knowledge. And column 3 provides considerations for adapting the practice for local use. You'll notice that some of the practices have dots, either yellow or green, in column 1, and others do not. If there is no dot, it means that we've seen this practice in use and it could be valuable for implementing a homebound vaccination program. A green dot is a practice that is tailor-made for the homebound population. And a yellow dot is an idea that we've heard about, but we've not actually seen in practice yet. So with that, we're going to take a look at the guide to innovative practices. And Shauna will stop sharing and I will start to share. Just take a moment, guys. See if this works. Okay. Shauna, are you all able to see my screen?
Not yet. It just says you started sharing.
Okay. Let's try again. You still can't see it?
Not yet. Do you have 2 screens, Marjorie?
Yeah, I do, but I did pull it down to the main screen.
And do you have the main screen selected when you pick share screen?
I don't know. But now I can't get it to show me the whole, yeah, I can't get it to show me the whole thing. Here's what we're gonna do. I'm gonna pinch it here. Sorry, guys, please bear with us a second. Shauna,
You can email.
Yeah, I'm gonna send you the link so that you can open it. Technology, right? Okay.
And just while Margie's working on getting that up, we will have this document available on our new website. But we are having a few technical issues.
If you could mute your lines, please. We're having some feedback. Thank you.
Oh, sorry. So we are having a few technical issues with our site, but hopefully we'll be able to put the link to this document, this guide in the chat before the end of this call. That is my goal.
Okay. Shauna, I just sent you the link to the actual guide so that you could share the screen. Here we go. Beautiful. And if you could make it just a little bigger, then we'll be in business. All righty. Okay. Thank you. And sorry for the pause, guys. So this is the beginning of it. It's dated April 28th, which is today, understanding that this is an evolving set of practices, and we fully expect that new innovations will emerge, and TIFA is prepared to continue to update this guide with new ideas and practices as they come into their awareness. So if you hear about practices, there's information in this guide about where to send ideas. And so forth. We'll get there in a minute. So as you can see, there's just a little brief introduction at the beginning, and then the section under the contents, all of these are linked. So you can see that the instruction is that you control-click on one of these categories so that you can get to that section of the guide. As Shauna scrolls down, you can see the How to Get Started section, which I mentioned earlier. And I'm not sure why it's formatted this way. We'll have to go back in, but there are the box here, the text box here tells you that if you want to learn about any of these practices in greater detail, or if you have your own ideas to share about additional innovative practices, you can send an email to the Age-Friendly Public Health System email at tifa.org. So AFPHS@tifa.org. You'll all have copies of this following the presentation, so you'll be able to see that. And then as you scroll further, you start to see the innovative practices tables. So Shauna, if you could scroll back up to the top so that we can see the table of contents once again. And if you could just control click on the one that's highlighted so that that's going to take us right down to that section of the document. Just control click on strategies for getting homebound, for getting the homebound with greater mobility to vaccine sites. It's not scrolling.
I am clicking on it, just so you know.
Taking a minute.
It's not linked to anything.
Is in mine. Let's try another one. Let's try expand and diversify the vaccinator pool. Just control click. It's the top of the next column.
Yeah, control click.
Not working. Okay, it must be because we're sharing. Because mine are all going. Technical problems. In that case, let's just go. If you can, just let's just go down to. Let's just proceed to page numbers. Okay, let's proceed to page 9. All right, guys, we didn't practice this in advance. Top of page 9 should be strategies for getting the homebound with greater mobility to vaccine sites. There we go. So here's an example of one of the categories, and you can see in this table, we've got several practices with details about where it has been done. If there aren't any considerations for local implementation, then that column will be blank. But in most cases, we have some thoughts about what you might need to bear in mind. And as you scroll down this table, you'll see that the very bottom one that starts on the next page has a green dot, which means that it's specifically related to the homebound population. Now, anything that doesn't have a green dot certainly is applicable to the homebound. It's simply that it's not only for the homebound. It's not exclusively for them. So for example, in the center of this table where you see the partnering with rideshare services, and the example is Lyft Vaccine Access Program, partnering with Lyft, obviously. This can be used for anybody who might need a ride to get to a vaccine center, but it's also applicable to those who are homebound. Whereas encouraging residents who have intentionally chosen to stay homebound to visit clinics is one that is specific to the homebound. So I think having taken a peek at all this, the only other thing I'll share is, Shauna, if we could scroll down to where the sources begin, which is on page 17, a little bit further down, you can see that rather than make the tables cumbersome with citations, what we've done is just added a list of alphabetical citations at the end. Most of these do have hyperlinks, so you can get to the original source. And again, as I stated at the beginning, this is a living document. It will continue to expand and evolve as new practices emerge. So with that, I think we can open it up for discussion and questions. Would love to hear initial impressions about this and thoughts about how you might use it.
And I just got the link and was able to put it in the chat so you all can access it now and review it and see what you think. We'd love to hear if you think that the organization is useful, if you know, the way that we've presented the information is going to be helpful, and what other ideas that you may have.
This is Kyle. I think it's a great resource. So I think just making sure that if you're that it's dynamic, that people know it, and kind of the dates of updates will be important. But my question was too, is how do you get this disseminated? So there's lots of different places, you know, even within like just CMS or Health and Human Services, that would be, you know, think about your distribution list, because I think there's lots of different people working on this. And so kudos to pulling it all together. It's a very, needless to say, it's a complex calculus, right, of trying to pull this together. So those would be mine. I would say great piece of work.
Thank you, Kyle. And yes, we will be disseminating to all the folks who have been involved in our convenings. And so that includes folks from CMS and CDC and HHS and the VA and ACL and so forth. But we will also be sharing through our newsletters, the main TIFA Prevention and Wellness Digest has a very large subscription list. And then we would hope that through our funders, through the Johnny Hartford Foundation and the Cambia Health Foundation, they have great communications teams, and so we'll rely on some of their connections and networking as well.
I think we should test this out. So, and what I mean by that is, imagine those of you on the line, if you're trying to do something and you're not sure how to do it with respect to ensuring that folks who are homebound have access to this vaccines, what is the question? And let's see if this guide can help us. Of course, I know you all have already solved all these problems, but take yourself back a few months before you got there.
So I'll pose one, Margie, just to get us started. In terms of covering the cost, right? So that is still, I think, going to be an issue, and not necessarily the cost of the vaccine, but the cost of delivering the vaccination and getting it out there. So why don't we test it that way? What do you think?
Okay, that sounds good. And so Shauna, I'm going to ask you to actually share again and take us to page 14. We'll have to get back in here and make sure these links actually work.
And Megan, while you're looking, Margie, I would also add that we were having a conversation today earlier with some other folks that were talking about dissemination as well, Kyle. And one of the things that they thought was going to be a big interest that they wanted to explore was definition.
Oh, good. Yes. Well, we'll get there next because there's a section in here for that too. So there is a category here for strategies and mechanisms for covering the cost of vaccines. And if Shauna, you could make it just a little bigger, those of us who are getting on in years need it a little bit bigger. I speak for myself, of course. So at the top of this section, there's just a little statement about the American Rescue Plan Act and the dollars associated with that, and the Coronavirus Response and Relief Supplemental Appropriations Act. And sort of how those dollars are being dispersed with respect to vaccines, and how some of that is relevant for the provision of vaccines to those who are homebound. And that's really just an introduction to all of this. Of course, for individuals, the position of the federal government is that this should not cost anybody any dollars out of their pocket, right? That it should be either covered by the federal dollars or covered by private insurance if that's what people have. But how that happens and how the individuals doing the administration get reimbursed is an open question, and how much they get reimbursed for their time and so forth. So if you look at our table, you can see the very first practice here, leverage multiple reimbursement strategies to cover all the associated costs. So understand, we're talking about not just the cost of paying for the time of the vaccinator. We're also talking about paying for the transportation of the vaccines, the keeping them cool, the waiting around while people, are, making sure they're not having an adverse reaction, and all of the documentation and follow-up and scheduling logistics. All of that costs money and time. So how do we pay for that? And the example that we had was from Bloom Healthcare in Colorado. Tom Lally from Bloom was one of our Huddle speakers a couple weeks ago. But the considerations are to think about reimbursement strategies that include state funding, FEMA dollars, commercial payers, and other insurers. But the example from Bloom is a good one because it is specific to those who are homebound. When the policy brief comes out, you'll see that there's a page-long case example of the Bloom story with a lot of details about how they pulled this off. So that's a great reference. Then we have several examples as we move down the table that are general strategies that don't necessarily apply to those who are homebound, but are still really important ideas and tactics to keep in mind. So using Medicare dollars, of course, reimbursing through Medicare Advantage, reimbursement through Medicaid, and so, of course, private plan coverage. Because CMS is requiring private insurers to cover both the COVID vaccine and its administrative costs. And that's a really important thing because that wasn't entirely clear when all of this started. But in fact, it is not just the vaccine itself, but the associated costs for that. So if a person is unable to leave their home and needs to be vaccinated in the home and they are privately insured, all of the costs associated with that should be covered. They should not have a copay because somebody had to come out to their house. And then continuing on, we see the last one here, last two here, reimbursing EMS and fire departments through the FEMA funds that came through the federal dollars. So there are FEMA public assistance grant programs for reimbursing funds that are used in this way. The Indiana health coverage programs was a great example. And then the last one here is a claim through HRSA. North Dakota Department of Health has been doing that for folks who are unable to pay. So this is a supplemental way of getting dollars for covering these costs. So lots of creative techniques and ideas here on that question. And I want to go back to Jane's question about defining the population. This has been a challenging question since the beginning of this initiative. It was really one of the first questions that we came across. So there are really two categories here that help us. Shauna, if you go first sorry, I'm on the wrong page.
Margie, before you leave that, this is Kyle. How burdensome would it be? And I know you don't want to do this for every one of the considerations, but what you just described as far as how people get paid,
Mm-hmm.
that link to that specific technical assistance for many different people would be extremely helpful.
And when you say the link to the technical assistance, you mean to those who actually implemented it that way?
No. If I was an EMS, where would I go find out the rules, the regulations, and the how-to of how to get paid? Or if I'm a Medicare Advantage plan, where do I go to understand the rules and regulations for that? So it's taking people to that site so that they would be able to pick up from there to figure out how to get reimbursed. So these are examples, but taking people to the legitimate site of where this has regulatory approval or state approval or whatever, that could happen. Do you see what I'm saying? It may be too big of a lift and out of scope of your guide, but it would be, if I was reading it and I wanted to know, okay, I want to know how to do that, and I can go right to the link to be able to figure out how to do it from my local area, that would be helpful.
So I think part of the answer to the question you're asking, which is a fabulous question, is in the sources in the guide itself. So there are 3 pages of sources in the guide, and some of those links, maybe it's 4 pages, some of those links do go to exactly those kinds of pages with information like that. But I think it's fair to say that it's not comprehensive. Because some of this information is information we learned about in interviews and in convenings that were, where we weren't given, sort of links to actual documents. And so yeah, it may be further research on our part that might be needed. I think it's, I can't speak for TIFA, but I think there would certainly be welcome if folks have specific links like that to be able to share them with the AFPHS@tifa.org email address so that this document could be updated with links like that. What do you think, Megan?
Yeah, I absolutely agree. And I do think that some of those links should be put right here in these tables. If we have them as the footnotes, then they should be put right in these tables. I think that would be really, really useful. And I think the kind of thing that Kyle is speaking to is that, for example, the 4th line where it says CMS coverage and reimbursement toolkit, that should be just take you right, a link right to the toolkit. I think that would be really helpful.
So to Jane's question, so the defining the population and identifying who are those we're targeting with these efforts is initially it's identified as part of the initial steps in how to get started. So in that section at the beginning of the guide, Shauna, if you wouldn't mind, back to page 2. I know it's tricky to be scrolling all over. That second step, who are we vaccinating, is really, it's going to be a matter of making a definition that includes, who their paid and unpaid caregivers are going to be, because it's important to be able to vaccinate those folks too, whenever possible. The idea here is that there are existing registries of people who are already, good, likely targets here. So folks who are receiving Meals on Wheels, folks who are benefiting from integrated care organizations, home-based primary care, home health agencies. All of these folks have lists of people that are already being served in the home. And so finding a way to integrate those lists, having immunization, integrated immunization, systems lists so that we can develop a list of those who are eligible and can be screened so that homebound persons, who really need it in the home can get it. But there isn't a uniform definition. We're still not quite there. And so localities and states are tackling this on quite an individual basis. Just to go to a few other examples here, if you go down, Shauna, to page 4, I believe, maybe it's 5. Nope, it's 5. Where we start with developing the list of who needs home-based vaccinations. You can see that we start off with that Meals on Wheels example, using client level data to identify the homebound. The example from the Michigan Department of Health that use data from integrated care organizations is one example. There, of course, are self-identification options, right? Providing people a chance to raise their hand and say, hey, I'm here, and having a central place for them to put their name on a list through a vaccine operations center. This was done in Chicago through the fire department. PACE in Southeast Michigan had a program that partnered with social services to identify folks, and then partnering with municipalities and places of worship, again, to help identify folks who may fall between the cracks. These are just some ideas. Obviously, there are all kinds of creative ways to do this. These are the ones that we heard about. If you have others that you know of, let us know so that we can list them.
And in the meantime, please do go in and take a look at that, click on that link that I posted in the chat and take a look. If you have time and can provide additional feedback, we would love to hear it. It is a dynamic piece of a dynamic resource. And so we want to make sure it is as valuable to the field as possible. So please do let us know of any additional thoughts that you have about it. And we look forward to hearing your feedback.
And with that, Shauna, I'll ask if you can take us back to our final slide from our slide deck. As you all know, we are approaching the end of April. And because we are approaching the end of April, we are also approaching the end of our Huddle series. So our next call will be on Friday, the 30th, this Friday from 12:30 to 1 o'clock. And this will be the final Huddle call in this series. Our featured speaker will be Trudy Rebert from the National Domestic Workers Alliance. We appreciate the thoughts and comments today on this guide. We're excited about it and we'll continue to build it. And we hope that you will join us on Friday and spread the word to your colleagues as well. We look forward to seeing everyone then. Thank you very much, everybody.
Thanks, everyone. Thank you, Margie. Great run through.